Hello, you're welcome to the Primary Sports. It is always lovely to have you here. Today we'll be continuing our discussion on the sepsis spectrum, and this is the part 2A of that discussion. And we shall be looking at sepsis in detail. Sepsis is defined as a dysregulated response of the body to infection, leading to a life-threatening organ dysfunction. It is said to be associated with several clinical and biochemical abnormalities. It is considered to be a common cause of morbidity and mortality, and the final common pathway to death in most infectious diseases. The definitions around sepsis are constantly evolving, and the main aim of this is to ensure that early detection of this condition is achieved. Uh, so this is why research is ongoing. Protocols are suggested and subjected um, to trials, to clinical trials, and all of that. And the whole aim is to ensure that sepsis is detected early and interventions are implemented so as to have a favorable management outcome. According to the World Health Organization, in its 2024 publication, sepsis was considered to be one of the most frequent causes of death globally. It is estimated that in 2020, about 48.9 million cases of sepsis were recorded, and of these, about 11 million deaths were recorded. And this represents 20% of global deaths. According to the American Association of Medical Colleges, the sepsis is a deadly leading cause of in-hospital deaths in the USA. It is estimated that 1.7 million cases of sepsis are recorded yearly, and of these, the mortality rate is 331 deaths per 100,000 cases. It is also estimated that sepsis causes the US government about $62 billion annually. In Africa, in a 2017 study, about 17 million cases of sepsis were noted, and of these, 3.5 million mortalities were recorded. In sub-Saharan Africa's hospital-wide prevalence of sepsis was found to be 17%, and the mortality rate was found to be 15%. In the intensive care unit, however, the prevalence and the mortality rate significantly increased, with the prevalence being 31% and mortality rate about 46%. In a local study in Nigeria, southeastern Nigeria, the incidence of sepsis was pegged at 7.41%, and in north-central Nigeria, it was found by studies that about 53% mortality rate occur in sepsis. Now, there are criteria that have been developed to try to define sepsis to help with the early detection of sepsis in clinical practice. The whole aim, of course, as I mentioned earlier, of these criteria is to ensure early identification. Now, two crucial criteria have been noted. One is that for sepsis to occur, there has to be a background infection. Now, this infection can be established, can be established or a known infection, and this is done through laboratory studies, okay, through laboratory studies, or it can be suspected. Now, suspicion of infection can be gotten through history, okay, or through physical examination. Okay, through physical examination. So, whether the infection is objectively proven via laboratory studies or suspected through the clinical processes of history and physical examination, this is one of the criteria. Now, recall that in the definition of sepsis, we noted that it is the response of the body's immune system to an infectious process, and this leads to life-threatening organ dysfunction. So, therefore, the second criteria for the definition of sepsis is a clinical evidence of organ dysfunction. So for this evidence, there have been several scoring systems. Several scoring systems have been postulated. Now, in the next few slides, we shall be looking at these scoring systems. One of the one of the oldest of these criteria is SIRS. Now, SIRS, we discussed SIRS in the previous video. SIRS stands for Systemic Inflammatory Response Syndrome. And we looked at the criteria for SIRS: respiratory rate greater than 20 cycles per minute, or partial pressure of carbon dioxide less than 32 millimeters of mercury. Talked about the temperature greater than 38 degrees Celsius or less than 36 degrees Celsius. We talked about the pulse rate greater than 90 beats per minute, and we noted the total white blood cell count. Okay, now these to be greater than 12,000 per microliter or less than 4,000 per microliter or more than 10% band cells. Okay, more than 10% band cells. Now, all of these were discussed in the previous video. All right, so you can quickly refer to the video for more details on search. Now, for search to be established, of these four criteria, at least two must be present. Any two must be present for search to be established. However, search is no longer used. It is outdated, it has fallen out in recent years. This is particularly because there are many non-infectious conditions that can cause SARS. All right, so this is why SARS is no longer used as a defining yardstick for sepsis. All right, for example, excuse me. For example, if an individual is involved in increased physical activities, say physical exercise, all right, you would note that due to increased sympathetic activities, the pulse rate of this individual will increase and the respiratory rate will increase. Now, the essence of this increase is for the body to meet up with the increased metabolic demands of the peripheral tissues. Remember that during exercise, more glucose, more oxygen is utilized by the peripheral tissue, especially the muscles, the skeletal muscles. All right. So for the body to meet this increased demand, it would respire more to deliver more oxygen for metabolism, and the pulse rate also will be high to deliver nutrient-rich blood to more nutrient-rich blood to the tissues. All right. So search is one of the criteria for the identification of organ dysfunction. However, it is noticed to be outdated. There are other criteria, okay, aside from SERS. There is the SOFA, the sequential organ failure assessment. The key SOFA, the quick, otherwise called the quick SOFA, that is the quick sequential organ failure assessment. We also have the national early warning score, among many others. So in the next few slides, we'll be looking at each of these scoring criteria briefly. The SOFA score, it's an important, it's one of the very important criteria used to identify organ dysfunction. So it has got six domains. All right, the respiratory rate of the respiratory system, beg your pardon. Coagulation is the second domain. The liver, the third. The cardiovascular system is the fourth. The central nervous system is the fifth, and this is the fifth, and the renal system is the sixth criteria or the sixth domain. So these are the domains of SOFA, right? Now SOFA is scored from zero here to from 0 to 4. All right. So as we migrate from 0 to 4, there is increased severity of there is as we migrate sorry as we migrate from 0 to 4, there is increased severity of what of the pathology. All right, so 4 therefore is associated with several bad outcomes, increased morbidity, increased risk of ICU admission, increased risk of mortality. All right. Whereas 0 here is associated with very favorable management outcomes. All right. The partial pressure for the respiratory domain, the partial pressure of oxygen is if it's greater than 400 millimeters of mercury, the partial pressure of oxygen or the fraction of inspired oxygen. All right. If this is greater than 400 millimeters of mercury, a score of 0 is given. Alright, with a declining partial pressure of oxygen, we begin to migrate towards the score of 4, such that if the partial pressure of oxygen is 100 or less, a score of 4 is given. For the coagulation pathway, we look at the platelet count here. Alright, greater than 150 times 10 to the power 3 per millimeter cube, score of 0 is given. And then with decreasing platelet count, again, we migrate towards 4. And if the platelet count is at least 20 or less, a score of 4 is given. For the liver, we look at serum levels of bilirubin. If bilirubin is less than if it is less than 0.2, a score of if it is less than 1.2, I beg your pardon, is a score of 0 is given, and if it is greater than 12.0, a score of 4 is given. Okay, hypotension is another. The cardiovascular system is the fourth domain here. All right, and this looks at hypertension. All right, if there is no hypertension, if this individual is normotensive, a score of 0 is given. However, if the mean arterial pressure is less than 70 millimeters of mercury, a score of 1 is given. If this patient needs uh, catecholamines to maintain normal tension, such as dopamine. If 5 um, micrograms per kilogram per hour of dopamine is needed, all right, or of dopamine or dobutamine or any dose of dobutamine needed, a score of 2 is given. If more than 5 microgram per kilogram per hour of dopamine is needed, or 0.1 or less than 0.1 uh, micrograms per kilogram per hour of epinephrine or norepinephrine are needed, the score of 3 is given. And then if more than 15 micrograms per kilogram per hour of dopamine is needed, a score of 4 is given. So you see that as we migrate towards 4, we tend to need more ionotropics, more catecholamines to maintain, to achieve and maintain normotension. All right, for the central nervous system, we look at the GCS, the Glasgow Coma scale. The maximum possible score for the Glasgow scale is 15. Of course, if this individual has 15, GCS of 15 gets a score of 0. With declining GCS, again, just like the other parameters, we migrate towards 4. So if the GCS is less than 6, a score of 4 is given. For the renal domain, we look at the levels, serum levels of creatinine. That's what we look at for the renal domain. Now, if creatinine is less than 1.2 milligrams per dl, a score of 0 is given. However, if it is greater than 5.0 milligrams per dl or greater than 440 micromoles per liter, a score of 4 is given. Again, for the renal domain, we also look at the urine output. Urine output, remember, um, if you recall, urine output normal daily the normal rate of urine production is about 0.5 to 1 mils per kg per hour. All right. So if this urine output per day is less than 500 mils, all right, this individual is given a score of 3, and if it is less than 200 mils, the person gets a SOFA score of 2. So this is how the SOFA score is used in identifying um, organ dysfunction. Okay, okay. So SOFA score is better applied in the ICU setting. Okay, SOFA score is better applied in the intensive care units. Okay, that's the ICU. SOFA score is better applied here. Now, if it is suspected that an infectious process is ongoing, or if it is objectively demonstrated that indeed there is an ongoing infection, and the SOFA score is greater than or equals to 2, a diagnosis of sepsis can be made. All right. Now, on this table, we try to look at uh, we try to juxtapose SOFA score with the risk of mortality. We see here that a score of 0 to 6 has just has less than 2% risk of mortality. However, as we migrate down the table, we will note that a score of 16 to 24 has more than 90% risk of death. Okay. Um, the strength of this super score is that one is that it offers a standardized approach to sepsis identification. All right, and it can also be used to determine the response to treatment. Now, these scores are done serially. All right, so as they are done serially, they are compared. All right, so the progress of the patient, the trend. All right, so a patient may have on day one of admission, for example, uh, a patient may have a SOFA score of 20. All right. But as the patient continues with management on the 4, 5, or 6 thereabouts, super score may, may come down to less than 10, or as the case may be. All right. So, like this, super score can be used to determine the response of the patient to therapy. It also predicts mortality. I mean, we just saw that in the previous slide where we noted that the score of 16 to 24 has more than um, um, 90% risk of mortality. Okay, now what about the limitations of this SOFA score? It is developed to be applied to group of patients or populations. It is not used in isolation. Also, it requires extensive clinical data, and these may not be readily available in low resource settings, as the case is in the underdeveloped and developing societies. All right. So, because it requires a whole lot of extensive clinical data, it is time consuming. So imagine a patient rushed into the emergency with possible sepsis, and the attending physician is trying to get this patient a super score to validate a diagnosis of sepsis. So we would imagine that in a typical low resource setting, for example, the turnouts of most of these investigations, they take quite a lot of um, take quite a lot of time for these results to be produced from the laboratories. And in some instances, the machines, the equipment needed to do these investigations are not readily available. So all of this will hamper or delay diagnosis of sepsis, and this may worsen management outcome. The next score we would be looking at is the Christopher score. All right, we noted earlier that Christopher is a quick SOFA score. It is a shortened version of SOFA, and as you would easily guess, it is very, very ideal for acute care settings like the emergency, the accident and emergency unit. It's also applicable at the bedside of a patient, but outside the ICU. With patients that are on admission in the ICU, the super score is is preferred. Okay, the QSOFA does not require laboratory investigations. It only relies on clinical science, and this cuts off a whole lot of delays that are suffered in the SOFA scoring system. So the clinician makes a QSOFA score based on clinical science. No investigations are needed. All right. So the QSOFA score four has got four domains. The respiratory rate of greater than or equals to 22 gets a score of 1 point. All right. If this patient has a GCS of less than 15, patient has an altered mental status. All right. A point or a score of 1 is given. A systolic blood pressure less than 100 millimeters of mercury, another score of 1 is given. To make a diagnosis of sepsis, as usual, there should be a suspicion of an infection, a background infection, or there should be a suspicion of a background infection, or should have been objectively demonstrated in the laboratory that indeed there's an infection. And if the Q-SOFA score is 2 or more, a diagnosis of sepsis can be made. The next score, okay, still on key super score, the strengths, it is simple as we see. Obviously, it is simple. All right, it has very few variables. It is therefore easy and quick to use. No investigations are needed. Of course, we already noted that. Entirely with the clinical signs the patient will present with, or the signs that the attending physician can elicit, the key super score can be developed. However, the key super score has got some limitations, and one of these limitations is that it has a very low sensitivity. And this excludes it to be used as a screening tool. Now, this is so because it cannot be used to identify subclinical uh, situations or subclinical organ dysfunction. Now, patients with subclinical organ dysfunction, in other words, they have an ongoing organ dysfunction, but they are yet to present with clinical symptoms. And recall that this skill so far only relies on, they are yet to present with clinical signs, I beg your pardon. And recall that this quick so far only relies on clinical signs. So because their presentation is subclinical, it is very common for these patients to be misdiagnosed, and this may create room for sepsis to progress to dangerous limits. Okay, so delay in identifying sepsis may amount to more adverse outcomes. Okay, yeah, and also the QSOFA does not consider diastolic blood pressure. It only mentions the systolic blood pressure less than 100 millimeters of mercury. It does not consider the diastolic blood pressure. The next score is the news score. This new score uses six physiological domains. The new score uses six physiological domains here, okay, or parameters. All right, and all of these parameters can easily and quickly be determined. It is noted to be superior to the Q SOFA score. Okay, it is superior to the Q SOFA score. Now, it was initially introduced in 2012. However, in 2017, it was modified. Now, what then is the difference between News 2, and News 1? Now, one important difference is that niche 2 considers a group of patients that have a different target. All right, niche 2 considers a group of patients that have a different target for SpO2. That's um, percent oxygen saturation. All right. Now, for patients, for example, with chronic hypercapnic respiratory failure, now the oxygen saturation target for these patients is about 88 to 92, yeah, millimeters of mercury. All right. Now, this is not captured in News One. News One just looks at the normal or the majority of the population. All right, so it does not make provision for these patients. So if these patients were subjected to the clinical significance is that if these patients now were subjected to News One for scoring, they will end up with high scores. All right, and this may lead to false escalation. All right, so to improve on that, the NIS 2, which was introduced in 2017, creates another column, as we will see on the next slide, for the SpO2 for patients with a different oxygen requirement. All right, typical example is the chronic hypercapnic respiratory failure. Patients with this condition, the target for their SpO2 is 88 to 92. All right, we'll see this shortly. All right. And okay, this the second difference I will show you just about here. Now, this is a new scoring system. All right. You will note again that as we mentioned um, earlier, it has got as you mentioned earlier, it has got six physiological parameters. Here is the respiratory rate. This is one. The one of this is SpO2. That is two. Systolic blood pressure is three. Pulse rate is four. Consciousness five, and temperature six. All right. So these are the six domains of the QSOFA, isn't it? Now, The score for Q-SOFA again is from 0 to 3. The lowest possible score is 0 and the highest possible score is 3. Now, 3 again representing very, very bad outcomes, increased risk of morbidity, increased risk of ICU admission, increased risk of mortality. All right, and 0 here is a good guy. All right, 0 is on his way, his or her way home. All right, so let's go through his scoring system. For respiratory rates less than or equal to 8, a score of 3 is given. Respiratory rate of 12 to 20 gets a score of 20. Respiratory rate greater than or equals to 25 gets a score of 3. Now, this is what I was trying to explain here. All right, so you see that we have two different columns for SpO2, isn't it? Yeah, so this first column is for the general population, where if the SpO2 is less than or equal to 91, this individual gets a new score of 3, and if the SpO2 is greater than or equals to 96, a new score of 0 is given. Now, this is a perfect score, right? Now, for a select group of patients, all right, with that require less amount of oxygen as compared to the general population. The typical example we noted are patients living with chronic, I'll just write this here, hypercapnic respiratory failure, right? Now, this group of patients here do not have the same oxygen requirements as the general population. So because of that, there was a need to include a different column capturing their peculiar oxygen requirements. So this is why the NIS2 score was made. All right, so SpO2 less than or equal to 83 gets a score of 3. 88 to 92 get a score of 3 of 0. Now you can compare that with greater than or equals to 96. All right, so you can compare. Of course, 88 to 92 will get a score on this other score, will get a score of 2 to 3, depending. All right, but on this other scale here, on this other column here, that is for a selected group of patients, as previously noted, 88 to 92 gets a perfect score of 0. All right, score of 93 to 94 gets SpO2 of 93 to 94 gets a score of 1, and SpO2 greater than or equals to 97 on oxygen gets a score of 3. All right, so the next parameter we'll be looking at is the systolic blood pressure. All right, the systolic blood pressure in the new score greater than or equals to 90 millimeters of mercury gets a score of 3, and 111 to 219 millimeters of mercury gets a score of 0. That's a perfect score, right? And greater than or equals to 220 millimeters of mercury gets a score of 3. For the pulse rate, less than or equals to 40 gets a score of 3, greater than or equals to 51 to 90 gets a score of 0, and if the pulse rate is greater than or equals to 131, a score of 3 is given. Alright, now for the level of consciousness. If this patient is alert, a score of 0 is given to the patient. However, you will see here that CVPU. Now, C here is another addition to the new 2 score. C is not was not present in the NIS 1 score. All right, so this is what sorry, just get this marker here. Okay, good. So this is what we're talking about, the CVPU, right? CVPU. All right. CS represents new onset confusion. Okay, new onset confusion, and V is verbal stimulus. Okay, so this patient responds to verbal stimulus. Probably you call his name or something, and then the patient um, responds, right? And P here is okay. Sorry, I'm just because I'm having some pointy issues here. So we have P here as pain, patients not responding to verbal stimulus but responds to pain, and U is an unconscious patient that does not respond to verbal stimulus and also does not respond to pain. Alright, so if any of these is present, a score of 3 is given. Alright, and remember that I mentioned that the C, that is the new onset confusion, was not present in the news one score. It is one of the new things introduced to the news 2. Yeah, so for temperature less than or equals to 35 degrees Celsius, a new score of 3 is given. Like this temperature is 36.1 to 38.0. This person gets a score of 0. And of course, hyperthermic patients with temperature of 39.1 gets a new score of 2. Okay, now these are the strengths of the new score. It aligns with the ABC protocol. You would notice that ABC is a common protocol for assessing patients, and the new score aligns with that. So you can see A is airway, you can see respiratory rate, SpO2, and all of those. All right, B is breathing to SpO2, oxygen, and all of those. C is circulation, you can see the systolic blood pressure and the pulse rate. All right, so the new score aligns with the ABC of assessing the patient. Okay, it also considers patients with different oxygen saturation targets. Now, this is actually very, very beautiful because patients with a lower oxygen saturation target would be wrongly escalated if they were subjected to the NIS1 score. All right, so this is also a very important advantage of the NIS2. And then it records actual values of measured physiological parameters. All right, so you can see here that actual values, all right, of measured, unlike the other scores that do not have actual values. The limitation is that the systolic blood pressure is not included. Again, this guy includes only the systolic blood pressure, and it is not considered a problem until it increases to 220 millimeters of mercury or more. Now, this is way too much. All right. Also, there is difficulty in identifying a new confusion or new onset um, confusion. Now, this is particularly possible if a new physician is seeing a patient. Of course, this physician can easily refer to the records of this patient, but in some instances, the physician may not have the time to refer to the records of this patient. So, at such instances, it would be impossible, or no, it would be difficult, all right, for the physician to say if a confusion state he or she is seeing at the time of review is an old symptom or sign that has been there before the patient is presenting to this clinician, or if it is a new feature to note. All right, so as a result of this, there is inappropriate escalation. Okay, we'll now discuss the risk factors for the risk factors of sepsis. All right. These they are quite enormous. The list is almost endless. All right. So these does not capture all of the risk factors, but I think it does a fair job to capture a good number of the risk factors. So again, you have an infection here together with an exaggerated immune response, and this will give rise to sepsis. Now, one of the very common risk factors is extreme of ages where we have individuals 65 years and above or and children less than 1 year old. All right, the immune system of these individuals is, it's not functioning optimally. All right, so with this suboptimal immune function, there is an increased risk of infections, and with this increased risk of infections, there's also an increased risk for sepsis. Remember that whenever the risk for infection is increased, there's a concomitant increase in the risk of sepsis, essentially because with infection, of course, the body would respond, and with this response, there is a possibility that the response will be exaggerated. Comorbidities can also give rise to sepsis or increase the risk of sepsis. Obesity, for example, um, increases the risk of diabetes mellitus. And DM is a state of it's an immunosuppressive disease. Alright, so there is immunosuppression in diabetes mellitus, and with this immunosuppression, there's an increased risk of infection. Also risk for ulcers, most commonly diabetic foot ulcers. Alright, these ulcers will serve as a focus where these ulcers can easily get infected. And when they're infected, there could be transport of bacteria into the general circulation, give rise to septicemia, and eventually give rise to sepsis. Other risks or other comorbidities, a very common example is malignancies, right? So malignancies, you have intra-abdominal malignancies, gynecological malignancies, breast cancers, and all of these. All right, the tumor can serve as a nodus. In some of these cases, there could even be ulcerations of these tumors. All right, so with these, the risk for local infection and then septicemia and all of those can come up. So other immunosuppressive diseases, commonly retroviral disease, uh, can also increase the risk of sepsis. Also, retroviral disease does this through two ways. One, an outright suppression of the body's immune functions, and also with the progression of RVD, there is a risk of formation of skin lesions, commonly sarcoma, which is a malignancy itself. There's also the risk for ulcerations and again transport of bacteria to the general circulation and eventually sepsis. Alright. Okay. So well, even abdominal and we can look at surgical conditions like appendicitis, right? So appendicitis is the inflammation of the appendix. Alright, so this can be, the ascending colon, and right here you have the appendix. So a fecal is here blocking the appendix, and we have increase in the intraappendiceal pressure. Now it gets to the point that the intraappendiceal pressure becomes greater than the pressure of the appendiceal blood vessels. Alright, so this compromises perfusion. Okay, this compromises perfusion of the appendiceal tissue. So we can diminish perfusion and with the ischemia. All right, ischemia can progress to outright necrosis, which can give rise to perforations. All right, with these perforations, there could be leakage of appendiceal contents into the peritoneal cavity, right? Of course, this will give rise to intra-abdominal, this will give rise to peritonitis, okay, peritonitis and intra-abdominal sepsis and translocation of bacteria to the general circulation, septicemia and eventually sepsis. Okay, there are other GIT pathologies that can act in a very similar fashion, including intestinal obstruction, including peptic ulcer disease, perforation, okay, or perforation from any other cause. All right. So intestinal obstruction also could give rise to translocation of intestinal bacteria to the general circulation, and of course sepsis, PUD perforation give rise to peritonitis and intra-abdominal sepsis and eventually septicemia and sepsis. So you can see that the comorbidity to sepsis is quite endless. You can also look at urinary tract infection, especially in the elderly population, where an ascending infection that eventually involves the kidney or the upper urinary tract could give rise to pyelonephritis and eventually urosepsis. Okay, even from the respiratory tract, also lower respiratory tract infection like pneumonia can also give rise to that. Institutionalization, um, hospitalization. All right. So nosocomial infection or healthcare associated infections. All right. we can give rise could can again with infections there's a possibility that while the body is reacting in response to this infection, this reaction can be exaggerated and amounting to life-threatening organ dysfunction. So this is sepsis in itself. So once there's an infection, there's a risk for sepsis. Alright, the use of medical devices for intranasal cannula to intravenous catheters to urethral to intravenous cannulas to urethral catheters. So all of these invasive procedures could go along with contaminants that can escape into the general circulation and give rise to sepsis, metabolic disease, malnutrition. Again, this is another risk factor. So extreme, right? Could be it could be excess, as in obesity, okay, or that could be a lack. All right, lack here can give rise to hypoproteinemia. All right, cachexia as the body goes into catabolism. Now, this reduces proteins. Proteins, of course, are building blocks for the synthesis of immunoglobulins. Alright, remember, immunoglobulins are proteins themselves, they are globular proteins. So, if they're involved in the humoral immunity. So, if the body is lacking proteins, the body is lacking amino acids that are needed to synthesize immunoglobulins. And with these immunoglobulins, if the body does not have enough immunoglobulins, the immune function of the body will be suppressed or will be suboptimal, and this increases the risk for infections. Um, Sarcopenia also is quite similar, it's a loss of muscle mass, and frailty, immunosenescence as seen in old age, and inflammation in general. So all of these are risk factors for sepsis. The causative organisms are commonly bacteria. Um, Gram-positive can be gram-positive or negative. The most common gram-positive bacteria causing sepsis is Staphylococcus aureus and also Streptococcus pneumoniae. The gram-negative bacteria Escherichia coli, Klebsiella species, Pseudomonas aeruginosa. These are very common organisms that can give rise to sepsis. Viruses also fungal, so Candida aspergillus. It is important to note that in more than a third of cases, the causative organism for sepsis is not identified. This image just further discusses this image discusses the focus for sepsis. So when we talk about focus, um, we're talking about the source of the infection or the origin of the infection. Okay, now so that's exactly what this image does. The most common focus for sepsis is the lower respiratory tract, right? Lower respiratory tract infection, as we have here in pneumonia, all right? Or other very common sources of focus, or other very common sepsis focus include the GIT, so abdominal infections. We've already discussed appendicitis. Okay, could be infectious diarrhea, gallbladder diseases again. The gallbladder can perforate. Yes. The urinary tract is the most common in the elderly population. Alright, in those on admission can actually come down with urinary tract catheter-associated urinary tract infection, and then this can climb up to cystitis, pyelonephritis, and all of that. Another way this can happen is through stasis. With infection, um, um, comes the increase there's an increased risk of formation of renal stones, and renal stones can obstruct the outflow of urine, giving rise to urostasis of urine. So this in itself would act as a focus for as a culture medium. So this can multiply the bacterial load, or there could also be a backflow of urine, to climb up towards the um, towards the kidneys, right? So we have the urinary bladder, and this is the urethra. And this is the urinary bladder. Sorry, this is the urethra. All right, and the ureters are here going here to the kidneys, right? So let's say a blockage, say somewhere here, bladder outlet is obstructed, there is collection, there is urine retention here, so the urine can backtrack, giving rise to hydronephrosis. It goes up again, giving rise to so this is a hydroureter, sorry, hydroureter goes up again, giving rise to hydronephrosis, and from here pyelonephrosis and urosepsis. Okay, so you see the pathway. There's an obstruction here. There is, retention of urine here. Urine as here comes the focus. Can even give rise here to cystitis, where there will be increase they have inflammation of the bladder wall. Yes, inflammation of the bladder wall. Okay. Aside from that, the urine can also backtrack to accumulate here, the ureters to cause a hydroureter, and then up the kidneys, hydronephrosis, and then pyelonephrosis, and urosepsis eventually. Cause skin infections are another possibility. So you have skin infection, skin and soft tissue infection here. We mentioned some earlier, obesity, being bedridden, okay, being bedridden, okay, bed sores, all right, obesity, can compromise venous um, the flow of blood through the veins, and this can give rise to venous ulcers. Venous ulcers forming can act as a focus again for infections. All right. Also, cellulitis. Yes, cellulitis. Okay, cellulitis, soft tissue. Okay, cellulitis here. All right. All of these can act as focus for CNS infection also is a possibility, not a very common one, but infection of the central nervous system giving rise. Typical example is meningitis, where there is an inflammation of the meninges, the meningeal coverings of the brains, and this can also give rise to sepsis. So far, we have been discussing sepsis. We've looked at the definition of sepsis, the epidemiology. We've also discussed the criteria and the several scoring systems for multiple organ dysfunction. All right, we've also progressed to discuss the risk factors of sepsis and then the focus. The next part of this presentation would entail the pathophysiology of sepsis, the clinical features, and the management of sepsis. Now, all of these will be delivered in the part 2 of this video, which will be out within 48 hours of release of this part 1. So stay tuned. Thank you very much for being here. Um, Kindly like this video and subscribe to this channel if you're interested in what we do, and share this channel on your platforms, please. And yes, make some comments. I'll always be there to respond. Thank you very much.